So in the space of just 35 minutes, I know Sue's going to be on my case if I go too long. I'm going to try to run through some of the rationale that we have for healthcare reform, and I'm going to zero in on the Minnesota Health Plan, explain some of the features of that, and then talk a bit about the politics around getting it done, which are complicated. We'll explain that. I've been told that this group may, at least a substantial portion of this group, may be a bit predisposed toward an alternate solution, such as single payer. So I won't dwell on a lot of the information. However, I do need to set up some of the issues that we have with our current healthcare system so as to be able to have talking points, if you will, primary issues to which we can return when we're defending an alternate way of doing it. Welcome, Senator Carlson. I'm really, thank you. And thank you for coming. I'm really surprised you could get away. So I think we'll turn now to my favorite subject, and that would be me. Just a couple of words by way of introduction to elaborate on what Ellen said. I am a retired guy. I was at McAllister College for 20 years and another institution before that. And in '05, when I sort of hit the streets after not working, I decided this was going to be the payback period for my life. And I ended up working with the DFL Progressive Caucus through its many ups and downs. And lately, I've been graduated, I guess, to the Senior Caucus, working with them. I was on the DFL Central Committee for a couple of terms and on the Platform Commission, so I've managed to keep busy. I had to decide on a focus, and as Ellen said, I did end up on the healthcare issue, working very closely with John Marty, who came up with the Minnesota Health Plan in very late 2007, and it's been in the legislature ever since then. My orientation toward healthcare was helped by my own story, we all have one, I guess, about our healthcare system. And that story had to do with this person, whose name is Nora. Through that 20 years at McAllister, a department head who reported to me, I happen to know, had a wonderful family, spouse, and 3 daughters, of which Nora was the oldest. Long story as short as I can possibly make it, Nora graduated from college about the time I was retiring, started, as it often happens with young people these days, started a series of jobs, some of which had pay and benefits, and some of which didn't. She had a collection of symptoms and attempted to find health insurance to meet her needs, ended up in the morass of state and federally sponsored programs trying to navigate her way through. Some of the money that she earned in a retail job disqualified her for getting onto a state program for a year out. It just went on like that, ungodly complicated. I watched this happening. I watched her parents attempting to intervene. It's a delicate thing. You don't want to sort of direct your child's life, but on the other hand, obviously things were not going well. She eventually found her way into a community clinic, which referred her immediately to Abbott Northwestern, and she entered there under uncompensated care. They took a 14-centimeter tumor off her adrenal gland, and it was too late. Essentially, it had gone on too long. She lasted a couple more years. She died at home on May 9th, close to this date, in 2009. I learned something about healthcare from Nora's story. It made me think about what it is that we want out of a healthcare system. Crystallized a lot of that for me. If I turn that over to you, if you were to give me 1 or 2 words of what you want from a healthcare system, what would it be? Just shout it out.
Less confusion.
Okay, streamline, simple,
Quality.
okay, access, quality, affordable. I'm sorry?
Immediate.
Immediate, so no barriers to get to see your doctor. Yes, sir.
To be able to compare costs at different hospitals and institutions and forms of treatment.
Okay, that one is very complicated, and I'll try to touch on
I'd like to
that.
have that be possible, that no matter what you choose, it's you, not a cost system.
Right.
Everyone's different.
Yeah. Yeah. So that one is very complicated, but I'll try to hit that. Yes, sir.
Humane.
Well, basically, I guess the overarching issue here is that I came away from Nora's experience thinking, my God, I live in a first world country. How could this be happening? So, yeah. Yes, ma'am.
I was going to say that I wanted my doctor to be in charge of what I can have done or do, rather than
Yeah.
some bureaucrat telling me.
All right. Later in the presentation, I don't mean to make light of the point, but I have a cartoon in which I will hope to remember to point out to you. So simplify, make it cost effective, reveal some of the costs to us, make it humane. Frankly, these are not surprising issues. And indeed, most of the healthcare systems in other worlds manage to hit these characteristics. And I'll explain, hopefully, how I think we can too. Let's take Nancy, my friend Nancy in the back there called out simplification. So let's have a look at that issue. I happen to have a friend who advises seniors in the central part of the state and the 7-County Senior Federation on just the issue that Nora faced. That is navigating through our healthcare system with or without the Affordable Care Act. She managed to reduce our healthcare system to one graphic to help people understand it. And I'll show it to you. Here it is. Any questions?
Where does it start?
Where do you start? Anywhere you can get into it. The interesting thing about this is that I won't spend too much time, but almost all of this remains with the Affordable Care Act. It's just that with the Affordable Care Act, we have a new layer, the exchanges, through which you go in order to access many of the services that are being satirized here. Also, we have the David Feinwachs issues built into this rather sarcastic cartoon as well. So, is the Affordable Care Act going to help us in this simplification issue? Well, the Journal of the American Medical Association also put together a graphic for its doctors to try to help them explain to patients how to navigate the system after the Affordable Care Act. And this is a fuzzy slide, sorry about that, but you get the picture. This is not simple. So we're not really fulfilling that criteria. There's a real consequence to this complication. It's easy to make fun of, but the consequence is cost. And I want to make the case to you that it's the cost and the prices that are one of the two major problems that we have with healthcare in the United States that actually are not going to be solved by the Affordable Care Act. Many of us in single-payer land often quote 31% of our healthcare dollars go into administrative overhead. That is based on this particular study that was published in the New England Journal of Medicine in 2003. And these investigators, who are all associated with Harvard Medical School, compared the United States and Canada, not that we need to import Canadian healthcare, but just as a benchmark for the finances, looked at the costs that we incur in the United States for all of our administrative overhead versus Canada. And basically, we found out that 31% of our dollars are going to administrative junk in our healthcare system. It takes some administrative junk to operate a healthcare system, but in Canada, it's only half as much because they have national health insurance and a simple system. We can get a little more complicated on this if I can stretch your patience. This has consequence for us as individuals. Even when we walk into a doctor's office, there is an invisible premium that we're going to pay to that doctor because that doctor's office has to handle the extra administrative overhead of our system. So they analyzed that, and they did it by taking and this gets a little wonky, sorry about this, they took the overall administrative costs of the American and the Canadian healthcare system, they broke it down by industry segment. So for example, your doctor's office would be this, the provider overhead. And then they broke that down on a per capita basis so that they could compare the United States versus Canada. So without going into a lot of detail, just look at the difference in the numbers and then multiply those differences out for an entire healthcare system. So obviously, we've got a huge problem here with administrative overhead. And I'm finding I'm talking way ahead of my notes. So actually that is one explanation for why our costs in the United States are so high, and Ellen mentioned this. There's different ways you can measure costs of healthcare in a country. In this case, I'm measuring it by the percent of the gross national product that are devoted to healthcare. The United States versus 3 of our competitors. I don't know if you can read that in the back, but it's Canada, Germany, United Kingdom, and the United States. Total health expenditures as a percent of GDP. If we had broken this down on a per capita basis, it would be even worse because of the mathematics, because our GDP is so very large. So obviously, we've got a huge issue with costs that derives from the administrative complications. The other issue that I want to press on you is that our high prices in the United States also derive from the fact that we do not take advantage of negotiation for prices the way other countries do. Here's one example. Drugs. By the way, I'm showing you a lot of data. I'm going to whip through it kind of quickly. I'm making the assumption that you are folks who have been dealing with issues such as healthcare in a fairly substantial way. And so you're perhaps not quite as turned off by the hardcore data as some other people might be. So that's an assumption that I'm making. But I want to demonstrate to you that this failure to negotiate has some real consequences. Here we have 4 popular drugs researched by Families USA, a very substantial, accepted, middle-of-the-road, frankly, healthcare reform organization. 4 typical prescribed drugs measured by the average cost of an annual prescription. If you bought that prescription through the Veterans Administration, you'd be taking advantage of a cost that was negotiated. The Veterans Administration goes to the drug manufacturer and says, I have 1 million users, and you can deal with me or I'll take a walk and find something else. Well, they get good prices. And as you might know, Medicare Part D, turn off your cell phones. Medicare Part D was specifically disallowed by law from doing that very thing, from doing that kind of negotiation. So you can see the difference, what happens in the costs paid by the individual for drugs. So there's an example of being able to negotiate.